Good afternoon. My name is Dr. Roy Joseph, and I'll be chairing this ethinar. On behalf of the Paediatric Ethics Programme of the Center of Biomedical Ethics, welcome to this ethinar on the holistic management of children with gender identity development issues. A special welcome to members of the Asian Pediatric Ethics Network. You'll be pleased to know that we have over 338 registered participants, and they are from 15 nations across the world. It's also important to know that about a third of our registrants are health professionals who are not doctors. The management of childhood developmental issues always require critical inputs and support from non-doctors. The wide perspectives that you bring will surely enrich our discussions and learning. Karen, may I have the first slide, please? Thank you for your valuable cooperation and support through participation in the survey. We did some totaling about 2 weeks ago. We can see that gender identity developmental issues are not that common. A good proportion of our registrants are seeing patients with these problems. Next slide, please. The findings from the survey also do indicate that learning across a broad front is desired. We intend that today some of your learning needs may be addressed. This afternoon, we are privileged to learn from 3 practitioners who have kindly agreed to share from their experience and expertise. As they share, it is likely that clarifications and questions will arise in your mind. Please post these, and the speakers will respond during the question and answer section. That will be after all the 3 speakers have completed their presentations. So let us begin our learning by welcoming Senior Consultant and Adolescent Pediatrician, Adjunct Associate Professor O. Jianian, who is the head of the Department of Pediatrics at the Kandankarbao Women and Children's Hospital in Singapore. Prof. O has a long and vast experience in caring for adolescents with a variety of distressing physical manifestations of developmental issues, including those related to gender identity development. Thank you, Jenin, for committing your precious time to this course. Please proceed with your presentation on gender development in children and adolescents.
Thank you so much, Prof. Joseph. I'm really privileged to be invited to speak at this platform today. So I'll proceed to start my talk by just the declaration that I have no conflict of interest in this matter, and my perspectives are also shared just as with the audience, just as a practitioner who sees children and adolescents. So I'm going to phrase the talk based on my own experience as a general pediatrician, and more specifically when I see adolescents in my adolescent medicine clinics. So the knowledge that I use when I manage children, in particular when there may be questions around gender identity and their development, this phase of their lives would be to understand the differences in terms of what gender means and what sex means in terms of biological sex, and also to apply the knowledge around identity formation and social emotional development in children and adolescents. Of course, I do want to keep myself abreast of certain definitions and jargon that my patients may actually bring to me, so that we don't fall into a trap of assumptions and presumptions, and to always clarify. But definitely, I think we do need to take into consideration that there may be growing evidence in the management of children and adolescents with gender development issues. So I'll just start, and I'll say that, I mean, this is not done in jest, but really just to illustrate the human side of things in terms of how we practice medicine. So I think, all of us know who this person is, right? I mean, you may identify Daniel Craig, right, as you know, as an actor, James Bond. You can identify him as being somebody who's muscular and handsome. And some of us, would then look into his role, perhaps as a husband, as a father. But actually, I mean, if we're thinking about gender, then yes, this is a man, right? In terms of how perhaps society has identified him. But how do we know, in terms of his sex, right? He is of male sex. So we do know, that biologically, the male sex has the XY chromosome. And from our embryology days, understanding the presence of the Y chromosome and the SRY gene that initiates male development in the fetus. And of course, how do we also know that perhaps, he is of male sex? Well, I mean, that probably, in our context at birth, the sex assigned, is based on the ambiguous nature of the male genitalia. But what is his gender identity? So this person's gender identity is based on their personal and internal sense of being a man. And if it is related to his male sex, then you would consider that there is gender congruence, okay? But can this be expressed through different ways? For sure. I mean, gender is also expressed through aspects of clothing or hair or behavior, but it's also to understand that gender identity is self-identified. And is as a result of the combination of inherent and extrinsic factors. And while on the other hand, we do know that gender roles are usually determined by our culture or community, and there can be certain definitions, based on the approach by the community, and there are certain rules, perhaps, that are placed upon certain gender categories. So I think some of you may recognize this very well-known Insta post, But to understand gender development in children, we do need to understand that this is different, perhaps, in terms of what we determine as the biological sex development. That starts in the intrauterine stage. And for sure, there is further sexual differentiation, with gonadal development, and finally, then the assignment of sex at birth based on the external genitalia. But we do need to take into consideration the social environment when we want to understand gender development. We already know that socially, there's a lot of prenatal planning that parents have once the sex of the child, is determined. Now that we can have obviously, diagnoses or ultrasound findings prenatally. There can be preformed ideas of, a child's preferences and parental aspirations just based on that sex. And of course, there's also going to be ongoing social interactions as the child is born. And we recognize, right, that there's rapid brain development in early childhood, which interacts with the environment. So as gender identity constructs become more apparent in children who become self-aware as they get older, We already know from our general sort of developmental screens, okay, this is when we try to understand their self-awareness and how, around 2 years old, children are conscious of physical differences between boys and girls. Mostly, okay, before their third birthday, most children may label themselves as either boy or girl. As with, a lot of our screening tools, okay, do try to elicit that. But as with all developmental milestones, I think we accept that there can be variation in when children can achieve, right, a certain milestone, and the same potentially would be of children who have that stable sense of their gender identity. We do need to consider, okay, the development of gender identity as well, together with how children develop from a social, emotional point of view. When we think about how children develop socially, there can be a preference for same-sex playmates by age 3 to 4 years old. But for sure, I mean, our children are all exposed to stereotypes of what may be deemed as masculine or feminine. I think as general pediatricians, we just need to obviously caution parents to perhaps avoid toxic influences by labeling girls as being weaker, as the weaker sex, and where boys should excel in sports or boys don't cry. And we do want parents to also consider where, as with all health and behavior development, it is a process, and that some children do exhibit variation. So for example, girls can refuse to wear anything that is pink, right? Or a young 3-year-old boy may think that a woman with short hair is a man. And many children will engage in playful dress-up activities and role plays. And a boy may, pretend to be the mom. A girl may dress up to be a construction worker. So these behaviors are obviously typical and expected. And it does not necessarily mean, right, that there's a developmental issue. Just to also emphasize that sexual development and gender development are not interchangeable. Physiologic sexual development progresses through childhood and adolescence and are distinguishable from gender-related behaviors. Of course, sexuality, though closely related to gender, may not always be defined by the patient's gender identity, and nor is sexual orientation synonymous with gender identity. What we are not discussing today, just to also be specific, are these group of disorders of sex development. But to illustrate, right, in some cases where newborns are when they present with ambiguous genitalia, the sex of rearing is determined by a multi-D team in partnership with parents, depending on multiple factors. Okay, but it's with the understanding, perhaps, that this child may actually develop their own gender identity over time. And of course, it is, again, a process. The next few slides, I will just want to share with you one of my patients that was referred to me when he was 15 years old. It was from a fellow colleague who actually has been following this child up for asthma. But the physician's main concern as he monitored the child's asthma is that as he became an adolescent, he noticed that he was becoming thinner and thinner and that he was losing some weight. And there was that question, of course, could this be an eating disorder? And the other sort of remark that he had made when he referred this patient was that he was a bit effeminate. When I explored the case, the parents' main concerns were actually not about the weight or his appearance, but merely that he actually takes too long to shower. He actually takes a very long time to get ready before he goes out. He takes a lot of time to present himself, in terms of how he does his hair and dresses, etc. Okay. And of course, adolescents being adolescents, his concerns was like, what's everybody's problem? I don't have a problem. So just to break it down, of course, I mean, the medical aspect of what I would be concerned about, is he really losing weight? Are there aspects of malnutrition or caloric restriction that I need to be concerned about. But actually, he did say that, actually he wasn't really trying to lose weight, but he was just very careful not to gain too much. And when I explored his body image and his concerns about it, there really wasn't there was no distress about that. He was actually very happy with his body image. At 15, he already was happy with the height that he had attained. He was already pubertal. But of course, I mean, there were some traits around perfectionism, orderliness, that his appearance must be just right. He permed his hair. It needed to be just right. In terms of his dressing as well, he needs to be perfect. So it did impair perhaps some of his functioning, where the time taken obviously made him late, made him miss out on a lot of the other aspects of adolescent life, right, that he's supposed to participate in. So at that point in time, I was mainly concerned about his disordered eating, but he wasn't malnourished. There was no signs of that. But as I referred him then on to the child and adolescent psychiatrist around those behaviors, he was actually diagnosed with obsessive compulsive personality disorder. And I suppose as I wanted to explore, where the parents did actually raise as a by the way, is this just a phase? Because we don't quite understand him. And although he, is a little bit preoccupied with his body image, this is the image, okay, in terms of what he would portray himself as. They do remember him as a young child, wearing a towel like a girl and, wearing a towel around his head, post-shower. But they acknowledge that, he was a happy child, no traumatic experiences, there's no learning disabilities, no ASD traits. So, as I spoke to my patient in our adolescent clinic, okay, we do have solo interactions with our patients after talking around the rules of confidentiality and safety. But actually his concerns was like, what's everyone's problem? I'm happy with how I'm expressing myself. I do have friends who accept me. But of course, we recognize that his friends were mainly girls. But he wasn't in distress. He didn't have a low mood. There were some experiences with bullying and teasing, but he just deals with it. And his main sort of narrative was that I just don't want to be muscular, okay? And I want to keep slim, okay? So I try to diet. So we do recognize that, especially in adolescence, that's a main phase of identity development. And when we consider how gender identity also develops during this phase, it's taken in conjunction with that understanding that teens will try on different identities, okay? But obviously, it is a key period where there is an overall personal identity development. And while puberty development presents secondary sexual characteristics and a clear change to their body image, really their gender expression may be more distinctive, masculine or feminine, or it could be neutral. And it is also fairly, I guess, acceptable that, kids may experiment and be a little more gender creative, and have a more creative expression, if you like. But we do know that gender identity can be influenced by pubertal development, emerging personality traits, peer interactions, and sexuality, okay? But while for some children, okay, by adolescence, gender identity may be a little bit more fixed, but in some, maybe still an evolving gender identity. So as I reflected on this case and I thought around what my duty of care would be, I felt, okay, that it was important for me to facilitate that open and not judgmental discussion with my patient as well as the family, that perhaps, okay, will allow some trust, okay, and acceptance of the medical advice that I would want to give them. I will also facilitate that healthy expression of emotions and perspective taking from my patient as well as the family, especially when there are matters that are controversial, sensitive, and especially if my patient may meet with stigma, bullying, and rejection. Of course, at this point in time, I would imagine that my patient outcomes, may include a social transition into a transgender identity. That's possible, but it's also possible that he may desist. And at that point, it was just an acceptance that there is a bit of that gender incongruence, and it was a non-conforming sort of expression. And he called himself actually more gender fluid. But mostly, I think an important outcome that I want my adolescent patient to have is to be a resilient and empowered young adult who understands safe boundaries in relationships and to reduce vulnerability, regardless of his gender identity, and to avoid being at risk of sexual assault or other mental health concerns. So he's now 16. He's of stable weight. Of course, there was some anxiety related to his OCPD, and because, of course, it was impinging on his function, right, in terms of the time taken around his appearance. So as he had to spend less time, on managing that, then the distress or the anxiety did increase, and he did go through some moments where there perhaps were some low mood moments, and he was started on fluoxetine. So as I approached the problem of, using the biopsychosocial model, I did caution him about the effects of malnutrition, and he stopped losing weight. Of course, I wanted to make sure that his thinness, wasn't currently causing harm, and had to balance the risks from caloric restriction. And he actually kept himself fairly sedentary, and his main contention was that he didn't want to develop a muscular sort of appearance. He also did speak with a certain tonal voice, and that I did explain to him could have also risks if he persisted to speak in that tone, and that could relate to vocal cord sort of distress and stress. From the psychological aspects, reducing that perfectionism, as I said, and the OC behavior, it does need to balance, because it did impact on his time for academics and time with his family. From a social development point of view, he didn't really care about pronouns used, though he was worried about coming out to parents around sexual orientation. There were some discussions about worries about national service, but he did have clear sort of career aspirations. He knew what he wanted to do in life. So just learning from this case, to me, it was about understanding gender diverse behaviors, and that potentially can be part of normal gender development. Whether this is a gender creative behavior, of course, thankfully, I think his family were fairly tolerant, but there can be situations where there can be familial and societal intolerance, right? And the experience can lead to, potentially higher and higher levels of distress as they get older. And of course, gender incongruence or gender dysphoria can be a definite source of distress for patients and families, depending on the context. So my reflection on that case was to continue to respond in a safe and non-judgmental way, and to balance the biopsychosocial needs of my patient, to pace with them, and to consider where, if it is beyond my ability and competence to manage that situation, then yes, to consult where appropriate and to prioritize the problems that may need treatment. I also, of course, did a lot of anticipatory sort of counseling around, and being prepared, if necessary, for memos or reports, for national service. But overall, I think that overarching lesson for me, was that this is still a duty of care to help my patient who potentially where there could have been distress from whatever the reason or cause of that distress may be. So this is my last slide, I think, just to tie up the learning points in terms of understanding gender identity development and its related issues is to remember that all individuals possess a gender identity and that the process of becoming aware of it is an important part of the psychosocial development of a child. We also need to recognize that gender identity is a developmental process rather than a particular milestone, and there can be variance due to societal norms, and that can potentially cause distress, both with the child and the child's family. It is necessary, I feel, to understand the varied pathways that lead to the development of a mature and healthy gender identity. And really, it's about achieving better health and well-being outcomes. And finally, I think as healthcare professionals, we are in a position to help by providing safe and effective medical care. And children and adolescents will benefit from the experience of being listened to carefully, to be given appropriate medical advice, and to be responded to with kindness. And thank you very much for listening to my talk. These are my references.
Thank you, Dr. Ho, for providing us with a strong and broad foundation and vividly illustrated by that particular child. Participants, will you please join me in showing our appreciation to Jenin? Thank you. I'm sure there must be questions and observations that would have come up. Please put them in the Q&A portal that you have access to. The chat function is closed because we don't want chatting, but put it there and we will address them. And Jenin, you keep a lookout for the questions that pertain to you, and we'll tackle these at the end. All right, fine. Thank you very much, Jenin, once again for giving the time. So shall we now move on to our next speaker? Let us now welcome pediatric psychiatrist, adjunct associate professor Ong Se Hao, who is the head of the Child Guidance Clinic at the Institute of Mental Health, Singapore. Prof. Ong too has a long and vast experience managing and researching the mental manifestations of developmental issues, and especially those arising from gender identity formation. Thank you, Se Hao, for accepting our invitation and sharing from your expertise and experience. Please proceed now with your lecture on the psychological dimension of gender development abnormalities. Over to you.
Thank you, Prof. Joseph, for the very kind introduction. I'm Se Hao. I'm the child psychiatrist from the Child Guidance Clinic, and it's a great privilege to be invited here for today's talk. A heavy topic, plagued with controversy, but very, very passionately discussed about as well. I'd like to make a few disclosures. I have no direct conflict of interest. However, I've been involved in the drafting of the national guidelines of the management of gender dysphoria in children and adolescents in Singapore. So today's topic, I'll be talking on the psychological dimensions of gender development abnormalities. I think apologies that there is a little bit of overlap with Professor Oh's lecture, but I'll definitely try to do my best to keep it interesting for you. So you've heard extensively from Prof. O earlier. I just want to emphasize and reiterate certain basics about gender identity. Sex being assigned at birth and gender identity are two separate things. Very often you hear about gender being a social construct. So sex assigned at birth is typically made based on external genitalia anatomy, but gender identity is the internal sense of being a male, female, or a gender along the spectrum between male and female. And people communicate their genders, the gender, to others through gender expression. And this may be done through mannerisms, behaviors, choice of clothing, and hairstyles. So gender identity develops separately from sexual orientation, which I'll talk about a little, in a short while. People's sexual orientation is related to whom they are attracted to on a physical, emotional, and romantic basis. So there is a difference there. So let's talk about the stages of gender development. Children generally start to understand their own gender identity and become aware of gender differences and stereotypes around age 2 or 3, with most children labeling themselves as either boy or girl by then. I'll just take you quickly through the different stages. Between age 2 or 3, there'll be a sex difference, the child being aware of the physical differences between boys and girls, and often identify themselves accordingly. At age 3 to 5, gender identity sets in. Children start to incorporate gender into their identity and become more rigid about adhering to gender expression, preferring to play with members of their own gender and engaging in gender stereotype toys and activities. Between age 6 to 7, there'll be gender constancy. Children begin to understand that the gender is stable and won't change even if they engage in activities or wear clothing traditionally associated with the opposite gender. Come age 7 to 10, there will be gender latency. The children become more relaxed about maintaining behaviors that are strictly male or female and may start to express preferences for activities or toys that are not traditionally associated about the gender. So there's also a period of reduced sexual interest about whether they're boy or girl, and a greater focus on social and intellectual development. And when they hit puberty, that's beyond 10 years old, SQUEN schema set in. This is during which children actively construct and internalize knowledge about gender, which they then shapes their understanding of understand better understanding of themselves and the world around them. So taken together, we know that gender identity development is a process. It is important to remember that gender identity development is a gradual one, and children's understanding and expression of gender may vary. And gender identity may not match assigned sex at birth. So some children may identify with a gender that differs from the one they were assigned at birth. And gender exploration is normal. Children going through periods of gender exploration through the way they dress, the toys they choose, and role-playing is normal and healthy. I think some of the audience from the younger generation, if I were to mention celebrities and musicians like Benson Boone and Harry Styles, you know that sometimes when they come on stage to perform, they may wear clothes that are more feminine or even dresses. For Benson Boone, he grew up in a family with mostly sisters and his mom. So there were a lot of influences on the way he dressed. So he went on to and he's was feeling very comfortable about wearing clothes that are more feminine as he performed on stage. The concept of gender identity and expression can be, like we said earlier, are different concepts. A child's gender identity doesn't always lead to a certain gender expression, and doesn't always point to the child's gender identity as well, vice versa. Gender expressions and behaviors might include, certain powerful behaviors, such as a girl insistent on standing to urinate, or the child developing an aversion to wearing the the bathing suit of the child's assigned sex at birth, or preference for underwear typically worn by a different sex, and a strong desire to play with toys typically assigned to a different sex as well. So gender is defined by the World Health Organization as a socially constructed characteristics of women, men, girls, and boys. These include norms, behaviors, and roles associated with being a woman, man, girl, or boy, and their relationships with each other. It varies from society to society and can change over time. If you look back to history, I couldn't even recall when the origin of eunuchs in various, ancient civilizations and dynasties. Certainly, there had already been, individuals cross-dressing and performing the role of the opposite gender. Gender identity refers to a person's deeply felt internal and individual experience of gender, which may or may not correspond to the person's physiology or designated sex at birth. Now, what are the psychological factors in gender development? One's gender identity is a result of a complex of psychological factors. On one hand, gender identity is closely tied to one's perceptions of themselves, that gender is a significant component of one's self-concept and self-image. When one's desired gender identity doesn't match the expectations of society, the self-concept can be negatively impacted. The personal experiences also heavily influence the development of gender identity, and everyone's experience with gender could be different, so there's no prescribed formula for how gender identity actually develops. But there are some pertinent factors that may contribute to or shape the development of gender identity. That will include childhood developmental history, any traumatic childhood and adolescent experiences, especially early sexual experiences. For example, I had come across very young, adult males or young men, and because as a child they could have been sexually abused by a family member or by a male stranger. When they grew up, they start questioning their identity and wondered whether they are females because they had attracted males to engage in sexual relationship with them. So their early childhood experiences are very, very important, and it's important to ask about them as well. Family history and relationships. It's definitely important to explore what the gender roles during childhood, including which gender was child raised up as, what are the role models available to the child, sexual exposure, and the teaching of sexuality in the family. Physical health problems and symptoms suggestive of atypical genitalia could also be one of the biological factor that shapes development of gender identity. Now, there are a few theories behind gender development, and I'll go into further detail. You might be aware of the social learning theory. So this is the modeling effect that children observe what other people do, and they obtain information about gender from the models in their environment, okay? From parents, from media, school, and peers. And then you have the social cognitive theory, which combines the theory of social learning with cognitive theories. So while modeling in social learning, which is informative, it doesn't explain everything. This is because we do not just model behavior, but we also monitor how other people react to our behaviors as well. So social influences impact children's development of gender understanding and identity. And the social cognitive theories explain and theorize that development is dually influenced by both biology and environment. Now, there's also cognitive theories of gender development. The commonly known one is the Kohlberg's cognitive development theory, whereby gender socialization occurs when children recognize that gender is constant and does not change. This is what we referred to earlier as gender constancy. Coburg indicated that children chose various behaviors that align with their gender identity and match cultural stereotypes and expectations. The more popular theory perhaps could be the gender schema theory, whereby children acquire knowledge about gender roles and develop their own gender identity. Though cognitive development theory and through cognitive development theory and incorporates some elements of social learning as well. Schemas are the beliefs and expectations of an individual about gender based on experiences within their culture. These schemas affect the child, the way the child processes information and how they retain such information about gender and influence the way they interact with the world around them. However, there's also a neurophysiological theory of gender development as well. So biological factors like genetic and hormonal influences that could shape development of gender identity and behavior. Theories suggest that differences in brain structure and function, often related to exposure to sex hormones during development, can lead to variations in cognitive abilities, emotional processing, and behavioral tendencies between individuals as well. While neurophysiological theories highlight the importance of biological factors, they do not suggest that gender is solely determined by biology. Now, I'd like to go on to talk about psychiatric conditions and mental illnesses, and invariably we refer back to the Diagnostic and Statistical Manual on Mental Disorders, or DSM. So this is what we use to categorize and classify mental health disorders, and also use it for research purpose to define patient types and for better effective communication between clinicians. Now, DSM-5, which is the 5th edition, TR means text revision, features the most current text updates based on scientific literature with contributions from more than 200 subject matter experts. The first DSM-5 was published more than 10 years ago in 2013, and the text revision edition was published just 3 years ago in 2022. So you come across, if you were reading the manual, you would come across homosexuality, and it was there in DSM, in earlier editions of DSM, but it then disappeared. So homosexuality is no longer considered a mental disorder. In fact, APA has removed it in 1973. Homosexuality is recognized as a normal variation of human sexuality following scientific evidence and increased societal understanding of sexual orientation. So ego-dystonic homosexuals it means that one's sexual orientation or attractions were at odds with their own idealized self-image, causing anxiety and a desire to change their orientation or become more comfortable with it. So it was first introduced in 1980, the concept of homosexuality as a mental health diagnosis in DSM-3, but it was soon removed after in 1987. So you can see that vacillation sometimes in scientific research and knowledge. So as we come to know more about certain conditions, we may decide to modify, add, or remove a certain diagnosis from the DSM manual. Now, gender diversity is a common term that we often hear about nowadays. There has been an uptick in the last 10 years in the proportion of transgender and gender diverse, or we call TGD, individuals seeking support and services through healthcare services as well. So researchers and clinicians generally use this as an umbrella term that includes a whole dimensional spectrum of gender identity conditions, such as gender non-conformity, gender non-binary, gender fluid, and others. And these are the common types of gender identity out there. By all means, they are not exhaustive, and more terms could be revealed in years to come. So I wouldn't go through them one by one, because you can easily assess that in the public domain. So what's the prevalence of transgender and gender diverse? So current estimated proportions of TGD people in the general population based on health systems-based studies is between 0.02 to 0.08%. But for children and adolescents, survey-based studies reported an estimate of about 1.2 to 2.7% of transgender identities, individuals. So these are the ones who identify themselves as transgender, okay? And if you extend the definition to a broader definition with broader manifestations of gender diversity, it goes up to 2.5% to 8.4%. So for children, variability in gender expression, as mentioned earlier, may start between 2 to 4 years old, and that's when they start expressing gendered behavior and interests. Very often, these non-conforming behaviors and preferences are transient in nature during childhood, and by about age 6 or 7, a child's gender identity may become more consistent. However, in most studies, the gender trajectories of prepubescent children are still highly unpredictable to date. So there are diagnostic classification changes in DSM. So TGD is generally not considered a mental, or rather a medical diagnosis, and they do not necessarily go on to experience mental health symptoms. However, gender identity disorder was introduced in 1980 in DSM-3, initially used as a diagnosis for both childhood and adult transsexualism, but with each different criteria. So since then, the American Psychiatric Association has replaced GAID with gender dysphoria, GD, in DSM-5 in 2013 to better reflect the focus on the distress and discomfort experienced by individuals. The change aimed to remove the stigma associated with the term disorder. And it is the only gender-related mental disorder in DSM-5. So even gender non-conformity itself is not a mental disorder. However, there is a provision for other specified gender dysphoria in the specific criteria for GD. These are limited to those who do not fulfill the full criteria for gender dysphoria. So this is again a hash of the DSM-5 TR text revision criteria for gender dysphoria. Again, this is something it's easy to understand, but because it's quite easy to understand them, it's also there's also a risk that it could be misinterpreted or being very subjective in nature rather than an objective assessment if you use this primarily to go about assessing gender dysphoria. So I wouldn't go through them because you can find them online if you just Google DSM-5 gender dysphoria. So what are the expected changes in gender experience and expression? So in the majority of children, symptoms of gender dysphoria may remit around or after puberty, okay? And there's this critical period between 10 to 13, as we've, to sort of help us determine, whether there's a greater likelihood to persist or desist, all right? As researchers have found that this is a more crucial age group that in the adolescence when they will become more sort of like affirmed in the way they see themselves. So the reason why this change, this crucial period, is because some of these individuals have stated that the multiple psychosocial factors affect their gender identities, right, during this critical period, such as changes in their social environment when they move up to a higher learning education, or the pubertal changes to the bodies, and also the first experiences of falling in love and also sexual attractions. So a lot of things happening within this age period, right? And sometimes that seems to have an impact on how the adolescent choose to persist in the gender identity or deceased. So experiences during this period and their childhood experiences often impact the development of their identity, well-being, and quality of life. Now, LGBTQ plus has been studied quite extensively. It aims to include all the various kind of gender experience and expression within a term, a name. As you can see, plus, because sometimes there are new identities being forged and they like to be included. So what is the relationship between this very special community and mental disorders? Now, the studies as depicted below have actually identified that young adults who are LGBTQ+ were at greater risk for developing major depression with odds ratio of 4, right, which is very high. And then you have other mental health conditions such as generalized anxiety disorder, conduct disorder, nicotine dependence, suicidal ideations, suicidal attempts, and also multiple disorders, multiple mental health diagnoses as well. So they are certainly at greater risk. And we also know of the high prevalence of comorbidity in children and adolescents with gender dysphoria, particularly mood and anxiety. And this comorbid diagnosis may occur independent of the GD, but also may interact with GD symptoms and affect its treatment. So results from prevalence studies vary greatly depending on the population studied. The most reliable diagnostic data come from clinical samples of specialized centers, but the findings are often not generalizable to the wider population of people with GD. And these are the correlations related to gender dysphoria, and we should always look out for as assessment of children and adolescents with gender dysphoria. This include intellectual disability, autism, spectrum disorders, depression, anxiety, PTSD, psychosis, eating disorders, body dysmorphic disorders, as well as borderline personality disorder traits. All right, I just want to highlight because I deal with lots of children with neurodevelopmental disorders. There is also several of my kids with autism have verbalized that they believe that they are of the opposite gender. And sometimes when you explore with them, it could be due, you've got to tease apart whether this are genuine dysphoria, gender dysphoria, or is it could be due to the fixation on the gender, the concept of the, being in the opposite gender. I had one kid who had been diagnosed with ASD, but experienced marked distress when he started to develop puberty, when he had a body hair, and that caused him a lot of distress there. Another kid of mine preferred the color pink, and he then concluded that he perhaps could have been a girl because of the favorite color. So you got to tease this apart and then discern whether this is actual dysphoria or it could be part and parcel of the preoccupation and stereotypical behavior and rigidity seen in kids with ASD. But nevertheless, researchers have found that the prevalence of ASD in GD cohorts could range from 14.5 to 68% in children and adolescents. But that's across various studies, but that's largely dependent on the methodology, the assessment, the cutoff points in the assessment tools, and so on and so forth. But certainly important comorbidity that we need to look at. So, of course, there are also psychosocial mechanisms for links with mental disorders as well. The role of more homophobic attitudes and stigma-related stress in provoking mental health problems in LGBTQ youth. The minority stress theory, which describes this group of people experiencing very unique stressors like discrimination, violence, and identity concealment that are linked to their sexual or gender identity. And then you have other social factors related to social integration barriers, such as low social trust, unemployment, and lack of stable housing. and the role of lifestyle choices made by LGBTQ young people, which may place them at a greater risk of adverse life events and stresses that increase the risk of mental health problems that could be independent of their sexual identity and orientation. So, of course, there are other contributing factors like biological factors out there, individual experiences, which I wouldn't go into detail, and also the research gaps as well. There's still a paucity of studies that could, help us better understand the specific relationship between GD and mental health disorders, and also to help us understand the complex interplay between these conditions as well. And of course, the relationship between the dysphoria and mental disorders could be bidirectional itself. So in conclusion, we have talked about stages of gender development and gender identity formation. We have social and learning theories, and we talk about neurophysiological theories as well. We appreciate that gender development may not always follow a normal trajectory, and there's growing evidence of gender identity being a dimension leading to gender diversity and non-conformity. And we now know that homosexuality is no longer a mental health disorder, and the gender dysphoria as the only DSM-5 TR gender-related mental disorder. Common comorbidities with other mental disorders are found in GD, and as clinicians, we should actively look for them and assess them and intervene when necessary. With that, I thank you for your attention. Thank you for bearing with me over such a long presentation. Thank you.
Thank you, Dr. Su, for opening up to us with great clarity the psychological dimensions of gender development, the associated abnormalities and the comorbidities, and how important it is for us as practitioners to have careful evaluation and understanding of our own patients. Thank you so much. My colleagues, please join me in conveying our deep appreciation to Prof. Ong. Thank you. Karen, you can put up these slides. Good afternoon. First of all, it is with much sadness and regret that I inform you that adjunct associate Chan Mei Yok is unable to be here now as she is grieving the sudden and unexpected demise just 2 days ago of an immediate family member. The last rites are now just about being completed. Prof. Chan conveys apologies. We are grateful that she had arranged for her presentation to be made. I have agreed to her request to present on her behalf. Thank you, Dr. Chan, for your thoughtfulness and the arrangements that you have made during your time of grief and sorrow. We convey to you our heartfelt condolences. Dr. Chan is a pediatric oncologist at the Kannan Women and Children's Hospital, an ethicist with a master's from the Harvard University, a member of the Paediatric Ethics Programme, and the organizer of this seminar. Her presentation is on the ethical management of gender identity. Yes. Right. When I speak, I will use the pronoun I, and that would be referring to Dr. Chan. All right. So, first of all, thanks, Professors O and Hong, for vividly and with so much clarity revealing the rich tapestry of gender identity development, its variations and anomalies, and the impact of this on the child, parents, and healthcare professionals. The issues in children, unfortunately, tend to be polarizing and politicized. We have to acknowledge that there are deeply held beliefs on gender development based on religion, social, and cultural norms. We just heard from Dr. Ong the large amounts of scientific data which reveal or which show the biological influences. So you can see there's a big chasm. Most importantly, we also need to acknowledge that the heart of the issue is a child or an adolescent in distress. And we have a duty as healthcare professionals to heed and address the issue, irrespective of our own beliefs and values. I will primarily describe the steps that I take or should take when faced with a child or parents with issues that arise from this developmental process. This requires sticking to a set of steps, just like inspection, palpation, percussion, and auscultation. I will also briefly cover how some of the more difficult situations can be managed. Let's start with a patient. This was a patient of mine in my earlier years. She presented in the mid-teens with a relapse of a chronic leukemia. The past history was that at the upper primary school age, she was treated with bone marrow transfusion and achieved a certain degree of remission. Now with the relapse, treatment with tyrosine kinase inhibitors is being planned. It is reported that she used to be a tomboy. During examination, it became apparent that she was trying to suppress her femininity by binding her chest. She had not volunteered any information regarding this previously. As a healthcare professional faced in a situation like this, what is the right thing you can do? I'm not going to make a poll, but I've offered some choices as to what professionals may do. Please study them, make a choice, and bring to your conscious mind your reasons for doing so. Mhm. As a health, I was shocked and also unsure of what to ask or to do, and hence did not ask her anything related to the observation of chest binding. Instead, I remained leukemia focused. Looking back, I have to say that I was not that ethical nor professional. Right? Asking and listening to a patient, even if a child, or when uncomfortable to us, is critical for laying the foundation of ethical care, especially when our emotions are aroused and our morality changed. So I usually begin by looking at the patient and the situation through the lens of the Beecham and Childress principles. From her sense of her autonomy, it is her body and her choice. However, she's only 15. How developed is her decision-making capacity? Then I look at beneficence. Is what she's doing helping her? Of course, I have got to find out from her what is troubling her, or as what Jenin mentioned, may not have been troubling her at all. Importantly, when we see behavior which is not usual, we have to look at non-maleficence. Is this action harming her? When you apply strapping and sticky stuff on your chest for an extensive periods, backache, skin coughs, restrict breathing, all these may develop. Would this affect the proposed treatment of the malignancy? Then justice is attending to this different behavior of hers, diverting us. Does it violate distributive justice? Is it a fair, equitable, and appropriate resource utilization to also, in parallel, look at other things that we find in her? Now, next is to very carefully, in a rational and objective manner, to obtain what we call an ethical history. And the Johnson's four-box method provides a good structure and guidance, moving sequentially through each of these subheadings. Information obtained next needs to be utilized. The ABC toolkit provides a structure and helps to maintain objectivity when emotions intensify. This toolkit was developed by Michael Dunn. Dr. Jonathan Chu from KK informally added a D and an E because after one has analyzed the facts, balanced and compared, there's still the hard work of deciding on an action and then subsequently evaluating the the efficacy and the effectiveness of our decision. Now, when we analyze facts and values, we analyze facts and values as far as this girl was concerned. And the contextual features provided much information. It appeared that the father had left the family to start another, and this happened soon after the patient's younger sister was diagnosed with a kidney tumor. Because the younger sister was being treated, the patient, our end, was left mainly unsupervised. Mother had no one to call and support because mother had fell out with her family when she married the father against the family's wishes. Hence, first diagnosis or concerns about altered behavior was delayed because mother thought that she was acting out. Just before and presented with a relapse, the mother was also diagnosed with a stage 4 ovarian cancer. You can see the large amounts of contextual facts that are present. All this is likely to affect the child in some way or other. Right? Would this have explained her behavior? Now, when it came to balancing principles and intuitions, found that notwithstanding the seriousness of her medical condition, N remained in good control, had maintained good control of her sexual identity development. She was able to uphold autonomy and preferences, namely, to be able to continue to bind and dress the chest while not producing many material harm. Attaining this balance meant that we could fulfill our duty of care to support her in her decision to dress in a certain way. We found that she did not require psychological or psychiatric care, but she did lose her life sometime later, almost 6 years later, in her early 20s, as a result of non-response to second-line chemotherapy and subsequent progressive non-compliance. It's important to be able to compare our decisions in one case with what we may have done if some of the factors were different. What if she was much younger and prepubertal? What if her parents were aware and supportive? How would we respond if the parents are unaware, or if they are aware, they are unsupportive? The key in all these is to try to be consistent in what we do. And we can attain this consistency when we keep in sight the ethical principles and the values of this patient that we're trying to uphold. Earlier, I had mentioned polarization and politicization because there is controversy. And the controversy arises because of legal perspectives and medical perspectives. Legally, because in the sense of human rights and how to balance the interests of affected individuals and the significant religious, free speech, privacy, and conscience-based interests of those who are asked or required to accommodate to these individuals. Today, we'll focus more on the medical perspectives. There are different causes for such behavior. It could be uncomplicated gender nonconformity, could be a body dysmorphic disorder, and other rarer causes. Say how I had mentioned some of these. So we must not be too quick to assume that the diagnosis is gender dysphoria. This is still, relatively speaking, a rare condition. Another source of maybe dilemma is where did the reporting of incongruent behavior come from? Did it come from parents or did it come from self? Secondly, are there external influences? This is important in today's social media powered world. Societal and cultural stereotypes also may play a part, and so also peer pressure and peer intolerance of any behavioral disturbances. Finally, we must also ensure that other mental health comorbidities, again, say how I mentioned these, are identified and treated or excluded. Barron and his associates identified two main therapeutic dilemmas that the practitioner will face. One is what is called the pathway dilemma, and the other one is the consent dilemma. In the pathway dilemma, there is the physiological or the non-physiological pathway. In the physiological pathway, puberty blocking agents and cross-sex hormones are given in the belief that this will address the child's distress at the incongruence versus at the incongruence. This is in contrast with the non-physiological pathway, where child is given time and space and counseling to explore the underlying emotions. But this should not be mistaken as being synonymous with forcing the child to convert to congruence. Counseling may help the child to work through any issues, bearing in mind that the majority of children who initially identified identity differences eventually resolve to congruence with biological sex. Now, the second dilemma is the dilemma of obtaining true informed consent from children. This is something that pediatricians are familiar with. There is no simple answer, and it will remain a perennial difficulty. Next. We can see that in this whole process that we need to adopt from the time the child first adopts till the child reaches a certain stage of stability, there are lots of uncertainties. How could we ethically manage these uncertainties? It's important for us to remember to make child-centric decisions and to use processes and frameworks. This helps us to prevent making subjective and impulsive decisions. To remain faithful to these processes and frameworks requires us to be humble. But we also need to be nimble to pick up subtle changes and to seek advice. Because very quickly or suddenly, the child may move into a stage where more stronger efforts will need to be made by specialists to prevent harm to the child. We also need to keep updated. You can see how much the literature has grown. There are journals devoted to this area. So there's a lot to be learned and updated. And finally, we have to remember to park our judgment and biases at the door. This cartoon illustrates our potential predicament. This is no excuse to abdicate our duties and responsibilities by ignoring the problem or by imposing our biases and our values on these children in distress. We can be sure we will remain ethical. Thank you very much. Now, we have now come to the end of the 3 presentations, and we move now. Thank you for showing your appreciation. I thought it not appropriate to invite you to appreciate, but thank you very much for the spontaneous noting. We have now come to the stage when we have time to pose our clarifications and questions. And to take us through this, we have Professor Dominic Wilkinson. He will conduct the Q&A and provide us with a summary of the key takeaways. Dominic is a professor of medical ethics at the Oxford University, director of the medical ethics at the Uhiro Oxford Institute, visiting Tochin Chai professor at the Center of Biomedical Ethics in the National University of Singapore, and consultant neonatologist at the John Radcliffe Hospital. Dominic is also a well-renowned researcher and an academic with extensive scholarship across the spectrum of pediatric ethics. Thank you, Dominic. Over to you.
Thanks very much, Roy. So we've already got some great questions in the Q&A. I'm going to ask our other presenters to pop their cameras back on, because I'm going to direct questions to them. I've been trying to listen very hard, so I haven't been monitoring the Q&A as much as I might. So when we're thinking about ethical questions, there are questions in a sense often about what we should do, and I think that's where I'd like to focus our thinking. There are often some very difficult questions about the nature of the world. Often when I think about these questions of gender dysphoria, I personally struggle with trying to understand how things have happened, or why a young person is expressing these particular wishes. I think the other thing that's really difficult to know, and Roy's mentioned uncertainty, is what does the future look like for this person? What will they want in the future? How will they look back on these? Both of those strike me as really almost imponderable. We can neither know exactly why, though as has been pointed out, there may well be factors that are contributing, both biological, neurophysiological, and of course environmental and personal. We can't predict for sure what's going to happen in the future, but we have to face these questions about what do we do now. That's where our focus should be. So that's where I'd like to focus our questions. I'd like to start with say how there are a couple of questions in the Q&A that you've already indicated you'd like to answer online. Perhaps if you'd like to start with this question about whether mental illness, including some of the comorbidities which you've highlighted are very common, are a contraindication to various forms of treatment for patients with gender dysphoria.
Thank you, Dominic, for the question, and to the audience who posed a question as well. The role of psychiatrists is largely threefold. I'm talking in general across all age group. So one is to establish the presence of gender dysphoria. Two is to assess for psychiatric comorbidities and intervene if necessary. And third is largely to determine mental capacity to proceed with any form of gender-affirming treatments. Now, treatments could be, of course, hormones and surgery as well. So, as you know, the prevalence of mental health concerns or problems are very real and are increasing in transgender individuals. But it doesn't preclude them from seeking medical, gender-affirming therapies. An important thing is that we need to make sure that the patient is stable in not just in the diagnosis of gender dysphoria, but also in other psychiatric comorbidities as well. For example, depression. So if the patient has severe depression, is suicidal, then this patient may not be a suitable candidate for gender reassignment or gender-affirming therapies. So the intent is that it's not that or because you have a mental health diagnosis or you have mental mental disorders, comorbidities, you cannot proceed to seek out gender-affirming therapies. The duty of care is to assess and diagnose appropriately and intervene should there be any active mental health problems that need to be addressed that would destabilize or the patient's mental state or impair judgment. Yeah, so definitely a patient with mental health diagnosis on top of the GD, once they are stable in their mental health conditions and has the necessary mental capacity to make decisions, he or she certainly could, seek consultations for further, gender-affirming therapies.
Thanks very much, Seha. One of the things that's been pointed out, we've already referred to the importance of the young person's capacity to decide. So their comorbid illnesses might affect that. That might be an important reason why you need to treat those before they could substantively engage in decisions, for example, about hormonal therapy or other types of therapy. But those other diagnoses are preclude the possibility of such treatments. I want to get on to thinking about substantive treatments, because we sort of danced around these questions, but they're kind of often the really tricky questions are about whether it's appropriate, when it's appropriate to engage in either puberty blocking or gender changing hormones, or forms of surgery, and that's often where the kind of really tricky questions get to. But I want to, before we get to that, I'd like to ask our panelists about language. There's a question about desisting versus persisting, and whether the language is problematic. I don't know whether, Jen-Yin, you'd like to come in on that.
I suppose in terms of use of language, I mean, my perspective is it really is something that perhaps these terms have been medicalized, I feel. And when we have these discussions, if I would imagine when there are cases, right, that we would need to, perhaps as a team in our different multidisciplinary type of discussions, is, you know, just to be aware of the use of language that potentially could, you know, perhaps bring through a more, I guess, a negative connotation, or a more judgmental type of a language. I think specifically these terms are not really something that in our practice, I think we use a lot of. It's not common that we use them. I mean, I suppose in terms of my own practice, we don't have many patients that we see with gender dysphoria, or when we talk to patients, obviously we don't use this type of language.
Good. So there's the two different things when we talk about language. One is, what language do we use when talking with patients? And I think there's some good examples in ethics of language that doctors might use separately, but that they don't use with patients. So in pediatrics, one common example is that we talk all the time about best interests, but actually even the language of best interest is not super helpful when talking with families or with patients or with young people themselves. Really, the fundamental question is what's going to be best overall, what might be harmful, what might do more harm than good. So the language of desisting or persisting might not be useful. One question is whether that sort of language is problematic even among ourselves when we use it. And as you've alluded to, if it carries connotations that are troublesome, that might itself be a problem. I wanted to pick up on an interesting bit of language that we've danced around, but that is itself, as many things are in this area, controversial, which is about the concept of gender affirming care and what that actually means. So I wonder if perhaps if Jen-Yin, if you'd like to talk about that, and then I'm going to come back to say how and what we take it to mean by providing gender affirming.
I mean, that's bounced around a lot, obviously, in discussions around treatment for gender dysphoria. But my view is that, I mean, we want to be providing affirming care, right, regardless of what the condition is. And actually, if we think back to how in the past, when we were, you know, starting to understand autism spectrum disorder and wanting to, you know, have even neurodivergence type of affirming care. So my perspective is that, I mean, affirming care basically just means that you validate the person's experience and not be judgmental about that topic or that subject. But it's just to try to understand what the difficulties and the struggles and the concerns are. That's affirming care. Yeah.
So Okay, so Janine, your understanding is that gender affirming care is sort of non-judgmental, except that's maybe a bit different the way that some people have understood gender affirming care, in that it involves, as I understand it, but others may correct me, accepting at face value that what the individual says is their gender identity is their gender identity. So that in particular, if somebody says I am female, though they were natally male, and therefore I want to have hormones, the assumption is that gender affirming care means acquiescing with the request that aligns with what they express as their gender. What do you think how do you understand gender affirming care?
Right. Yeah, thanks for the question. I think a lot of times there's still, it's a play of semantics. I know this. The intent is not to trivialize the matter, but I think different people have different takes on what it means. The jury is still out there, right? What actually means, because you can argue your point that, if you take it at a very literal level sense, it is, you give me what I want. That's how you affirm me. But in a medical context, it doesn't mean that what you want is the best for you. Especially, let's say, gender dysphoria or gender reassignment aside. If you ask for a certain medication that could cause you harm, so it doesn't mean that, because I need to be an affirming doctor, I'll give it to you, even though you have risk factors and contraindications for the drug or things like that, but we still give it to you nevertheless because you asked for it. So it's not like there must be a scientific and evidence basis to what we do. So in terms of gender affirming, I think the general consensus is, first, as what you pointed out earlier, is about, okay, what is evidence-based, what is in the best interest of the individual, and what that doesn't cause harm. And but you definitely have to weigh the pros and cons and have that kind of meaningful discussion about the benefits and the risk ratio with the patient or with the families as well. So I think it's important to you're right in the sense that we really have to set this out right. To talk about what do you mean when you say gender affirming. And I think for doctors in their practice, I think we should be mindful of that. What we understand, what we understood may not be what patients understood as well. And we need to clarify that at the get-go, at upfront, so that we are on the same page. Thanks.
Thank you. I want to before we move on very specifically to the sort of questions about hormone treatments, because often that's where it does start to get quite sticky. I wanted to draw on this question about respecting versus resisting the identity that a young person is expressing. So when young people start to express a gender identity that's different from their natal identity, one question for parents, I think, is to know how much to go along with that versus how much is appropriate to push back. Clearly, if the young person is going to persist in that identity, and acknowledging some of the challenge of using the language of persistence, then it's very important to respect that. If they are going to potentially change to their natal gender, then it might be the right thing to do to gently support and support them to do that. So I think that there's a tension both for parents and for clinicians because we don't know what their future trajectory is going to be. How do we support them in that process? And one of the particular claims, I think, that is out there is the idea that if you support in the way that you might be regarded as gender affirming, that you make it more likely that they will continue in their currently expressed gender incongruent expression rather than reverting to, as we've heard, which is a very common and developmental phase. So I wonder whether either Jinyin or Sehao would like to reflect on this question about whether when professionals or parents are doing what that sounds like there's very good reason to do, which is to be supporting adolescents in their expressed gender, how does that affect their subsequent likelihood of continuing or changing that expression of gender?
You want to go first?
Yeah, go ahead, Sehao.
Right. If I catch the question correctly, it's like, what role do parents have to play? Should they be, be encouraging or discouraging behavior? Am I right? And where do you draw a line as to, okay, this is my child needs to be evaluated by professionals and etc. Is that right, Dominic?
Yeah, so you made a useful distinction there. So we might be, so the young person expresses gender incongruence. Should we be encouraging, neutral, or discouraging in our response to that? And I think that might apply both to professionals and to parents. Should they be encouraging, discouraging, or neutral in response to that?
Yeah. Well, to answer that, there's no perfect right way, but generally, our stand is there could be other, there could be the gender dysphoria, if it's not a pure condition, is some kids may have certain questions about gender. It could be a smoke screen. So it's very important for parents to really have a conversation with the adolescents, like what is the child going through. There could be other things in, that could be going through. It could be issues about bullying. It could be in school. It could be other sources of stress, or there could be other mental health concerns, right? So I think it's important to have that. First step is to have the conversation, have an open, non-judgment conversation, and it is important to sort of like, acknowledge that the child has such thoughts or inclinations. All right, yeah, and I think it would be problematic if the parents would dismiss it at the get-go without listening the child out. So on the other hand, we also do not want parents to reinforce or stereotype gender behaviors, right? So, for example, I've a patient, a male patient who wanted to purchase cosmetics, right? Yeah, obviously it's problematic for the household, right? Yeah, so the parents would have to sit the person down, young person down, and have that conversation. And as much as the adolescent wish to talk about their problems or their dissatisfaction about their body or things like that, it's also important to hear from the parents, the point of view and the emotions as well. Very often parents go through this roller coaster ride, and not knowing what to do, what to expect from the child. So I think having that two-way dialogue is so important. So we always try to advocate for neutrality, impartiality, and non-judgmental to facilitate further conversations. And like I said earlier in my lecture, that sometimes it could be a transient period where the child is exploring the opposite gender behaviors. So having that ongoing conversation that the child feels safe to talk about it without being judged or dismissed is so important, right? So so that would be our stand. And at what point do you need professional help would be the degree of the behavior and also the extent as well as the distress that it brings about to both the child, adolescent, or to the parents and the household as well. When there was really increasing risky behavior or I have seen kids who threaten to self-harm, or and parents are being sort of like held in ransom because if they don't get the child something, then they will hurt themselves. So parents are often at a loss and may not know what to do and what's the best way forward. I think when it reaches that level of that distress and dysfunction in a family, then I think it's important to seek out a mental health professional. But of course, it could be allied health professional as well, a social worker, a psychologist, and not necessarily a medical specialist yet. But certainly, having that conversation that's ongoing, that's non-judgmental, would be the right step forward, and not taking sides or trying to reinforce or dismiss the child's behavior.
Okay, so it strikes me. It sounds though you're understanding the right approach is one of not neutrality rather than positive encouragement or discouragement. You mentioned something very important, which is of course the need to refer on, the importance of referring on in the context of distress, and in the absence of distress, there's presumably potentially no need to involve mental health professionals or others. That there are interesting questions which I suspect we won't have time to get to about psychiatric diagnosis and whether you need to have a psychiatric diagnosis to be able to access various forms of therapy. If somebody's, for example, not distressed but clearly identifying as a different gender, why do they need a psychiatric diagnosis then in order to be able to access, for example, hormonal therapy? But I want to move on specifically to some of these questions about therapy. One of the things that is relevant to these questions about treatment is best interest. Sehao referred to evidence and the importance of looking at that evidence, but there's great uncertainty about what the evidence says about, for example, puberty blockers or cross-sex hormones. Jinyin, do you want to talk about evidence and how we might make decisions in a context where there's very little evidence?
Yeah, I mean, definitely, we can draw experiences from other conditions where there is that lack of medical evidence. And it's always balancing, right, the benefits and the risks of any assigned treatment that we recommend, especially when there isn't sufficient information or experience. So I mean, in this context of especially pubertal blockers and hormones, as you mentioned, I think it's about laying out all the potential information that we understand from the impact to a young child who is perhaps going through many changes from puberty. So I think it's important to be open with parents and especially the young person themselves, and providing them with what we understand would be the most updated information, for example, and lay it out for them in terms of what are the potential pros and cons, and especially for an adolescent where this part of their decision making, okay, perhaps it's just developing the ability to weigh, things that would benefit them versus the impact or the drawbacks or the risks. So I think it's always having that open conversation. And also as a practitioner, really it's also being open and honest with your patient. If you don't have sufficient information, to, I think, have enough humility, okay, to be able to share that, you know, I'm not sure, and to get, you know, or refer on to practitioners that you feel would have more information, to have more knowledge of that evidence.
Good. So one way of responding to the uncertainty about evidence would be to see if there's somebody else who's got more experience, expertise in the area. That a second response, which you've pointed to, is the importance of openness and sharing the uncertainty about decisions with the young person and their parents. Of course, with the young person themselves, that becomes extra challenging because there are questions about, are they able to understand the great complexity of this decision. While we're on that, because we have a question on that, say, how do you think that? So let's pick the young person that Jen described at the very start. He wasn't seeking hormones, but had he been seeking hormones, do you think a young person of that age, say, how is able to understand the uncertainty about, so the question from the chat was about their future fertility, the possibility that they might change their mind in the future. Is a young person of 15 able to understand these sorts of uncertainties?
Yeah, thanks for the question. I think this is a very important point, because as much as we respect youth or young adults' autonomy and all that, but we've got to be very clear about whether, given there's so much information out there, and also whether the child is able to appreciate the gravity of the situation, the possible side effects to various forms of treatments and interventions, whether they have the maturity to consider all possible options, you know, out there, and all discussions about the condition and its treatments. So we often gravitate towards the age of maturity, which is age of majority, which is legal age of 21, right? Yeah, but of course we certainly do have older teenagers who are very mature, but also we have, on the flip side, we also have adults who are not really mature. In fact, in our clinical practice, I think some of us also felt that it's very difficult to really use a number to really to establish that. So you still need a lot of clinical experience and judgment to determine. But certainly at the age of 15, I mean, with so much things going on in the young person's life, it's like we got to really unpack everything, you know, like it's like peeling an onion, right? You got to peel from outside in and find out what's really at the core of the issue or the problem is. So I think we stand guided by international guidelines and standards. And of course, in recent years, as you have seen, there's a lot of backlash about offering gender-affirming treatments in the form of hormones or surgery too prematurely and leading to lawsuits. I think we got to actually take all this thing into consideration. Like on one hand, we want to support and advocate. On the other hand, there's also lack of long-term data and outcome studies. So we're trying to really strike a balance and give the best kind of advice that we possibly can to our patients and their families as well, and to manage their expectations when they do come. So at the age of 15, every individual is different. You really need to really work with the child for an extended period of time to really establish that. And then also think about the legality of and also the evidence-based regards to prescription of medicine and all that. Thanks.
Thank you. So the importance of not thinking about purely age, but the individual young person and their capacities, which are going to differ from young person to young person, differ over time. But you alluded to these questions about legality and also of uncertainty. And there's a question in the chat that's important. I want to get Prof. Joseph's thoughts on some of these questions, in particular about what should be lawful to prescribe in the context of some really profound uncertainty. So as others have mentioned in the chat and referred to, the UK has fairly recently moved away from prescribing puberty blockers outside the context of a specific research trial because of the profound uncertainty about the benefits versus the risks. Prof. Joseph, do you think that that's the sort of approach that Singapore should take in the context of this uncertainty? Or should it take a more permissive approach and allow individual clinicians, if they feel it's appropriate and they feel that the young person understands enough and the parents are supportive?
Thank you, Dominic. This is something that's happening in almost every subspecialty when you hit the boundaries of what we know and what we do not know. Personally, I think knowing all the disasters that have occurred as a result of well-intentioned interventions, I think it is important that when we hit uncertainty, we should always move forward in a research-like manner, such that we can always look back, evaluate, and decide whether a particular step was okay or not. That, I think, would probably be, especially socially, the most acceptable manner. Because we are not compelled. It's not a life-threatening situation where if you don't do something, the patient dies in 1 minute. You have time. You have time to plan all the research protocols, and it can come out. We know the different varieties. And when we do something like that, it really positions us to provide good information, which can then be built on. Thank you.
Okay, so that's an ethical argument in favor of research. We're running very short of time. It'd be good to pick that apart more, but we're not going to be able to. But I want to ask Prof. Joseph one more question, which came up in the chat, which is about the role of ethics committees or ethicists in decision making for young people with gender dysphoria, gender incongruence, requesting treatments, whether those are hormonal treatments or other forms of therapy. Do you think these cases should go through ethics committees, Roy? Is that the right approach in Singapore?
After listening, I am struck by the immense uncertainty that we have of the natural history of what we are trying to do, or what we are trying to treat. To put the decision to a bunch of, I won't use the word bunch, to a group of persons who probably have very little scientific basis, and then to decide whether it's okay to go forward in a particular case, I think is putting too much on the ethics committee. We have had to deal with this in other areas also, where the science has developed so much, but the people in the ethics committee do not know the science. And you can't expect them to understand the science in 2 or 3 days. So I think you really need, all institutions, all countries really need select committees, select groups of people who are well versed in the science, in the outcome, who can then formulate certain basic things that can be done or cannot be done, and how it should be monitored. That's probably a more profitable way. Thank you.
Brilliant. And so we are just about out of time. I'm going to just try and wrap up some of the threads that we've had from the discussion, some of the perhaps the take-home points. We've heard, of course, some of the enormous complexity and uncertainty of this area, but I think it strikes me that there are some things that we can be certain of. So one is that gender, expressions of gender are complex, that they're shaped by both internal factors and external factors, that just, and I wanted to reflect on one of the interesting challenges for us as a society. Just as the young person is experiencing change inside themselves and trying to work out how they respond to it, we as society are experiencing a moment of change that feels quite rapid and might feel uncomfortable. And there's a question about how do we respond to that change that of course is expressed in this debate, and that we as all as professionals, parents, as individuals, both at a personal and a professional level, respond to. So it's a question of how do we respond to change. One of the things that we've heard really importantly from our panel is the importance of non-judgmental acceptance, of, in a sense, of mindfulness, of being present with the young person in the place where they are, of listening to them, of exploring empathically and non-judgmentally their understanding of themselves, of paying great attention to any distress that they may or may not have, and of course providing appropriate therapy and support for that, and being open to whatever may come in the future, whether that's continuing in their current gender identity, identifying a different gender identity, and exploring in an open and honest way the possibilities and uncertainties about those. We've heard support for the importance at a societal level for thinking about what the appropriate policy is, some resistance to the idea of panels deciding for individual patients rather than, of course, the clinicians and family and young person themselves. We don't have, and we were never going to arrive at all the answers today. That's impossible in a short period of time, probably definitely impossible in the context of these very difficult questions. We have some questions we haven't managed to answer in the Q&A. I'm not 100% sure if we answer them subsequently, whether the people who've attended will be able to see those. We'll try and work that out, and if we can answer them so that people have access to them, then we will. I'd like to thank all of the panelists who've been part of today. Jian-Yin, Sei-Hao, Prof. Joseph, Prof. Would you like to close the seminar?
Yes, I'd just like to once again thank everybody, Jian-Yin, Sei-Hao, Dominic, Mayuk, for coming together and taking on this responsibility of surfacing what we know, what we do not know. This itself is a big step, and I think it's going to be a good foundation on which we can move forward. Thank you, Dominic, for the excellent summary and managing the Q&A sessions. We will certainly look at all the questions and we'll work out the answers. We plan to put the recordings up, and so at that point in time, we will probably put out the answers to the questions. I've just one request to all of you who have entered. We would just like you to take just a quick minute to address this feedback, and after that we can close the meeting.